Welcome to this week's lecture. We're going to look at a couple of different categories this week. We are going to look at feeding and eating disorders, elimination disorders, sleep-wake disorders, and sexual dysfunctions. Our first category is the feeding and eating disorders. And we're going to see this characterized by a persistent disturbance in eating or eating-related behaviors that results in the altered consumption or absorption of food. One of the things that we're going to note is that because food is involved, there's often an impact on the physical health as well as the psychosocial functioning. So we want to especially be sure that we are working with a physician, a medical doctor, with this client to make sure that they are going to be stable and safe. Because often when we see people who are engaged in some of these behaviors, we have some concerns over the health of the person in the long run or even in the short term. One of the other things that might be interesting to note is that there is some resemblance between eating-related symptoms and substance use disorders, such as the cravings or the patterns of compulsive use. And we see this because some of the same parts of the brain are being impacted, those areas that are engaged in self-control and reward. So in some instances, the reward might be sugar or a food substance. In some cases, that reward might be the substance being in the system. So the same parts of the brain are going to be triggered, whether it's sugar or cocaine, or at least similar parts of the brain, and a similar reaction to having that in the system is going to be present. We also notice, we'll hold that for another time. So we'll jump into the feeding and eating disorders, give you a couple examples of some specific disorders that you might see in your office. So pica is one that you will see most often in children, but you can see this at any age. Pregnancy is actually another time when this is fairly common. So this is the persistent eating of a non-nutritious, non-food substance over a period of at least 1 month. And again, as with all of these diagnoses, it has to be severe enough that there's some kind of impact, some kind of attention needs to be taken. Lots of different kinds of substances might be involved. This can include things like paper, soap, cloth, hair, wool, soil, chalk, gum, even metal, or ash and clay. What you're going to see in this group of folks is that there's typically no aversion to eating other food. So it's not that they are only eating these substances, it's on top of eating other foods that would be typical for their diet. It is important to note that there are some cultural components to this. So I think especially of pregnant women who in some cultures might have a kind of a history of people in that culture eating specific kinds of soil or clay during pregnancy. And this is often done because that people group has found that that soil or that clay has perhaps some calcium or some other mineral that the people need and that they might need more of it when they are in that pregnant state. So it's information that is often known to that specific culture, but from someone outside looking in, it might seem like there's a problem when this is actually a solution that those people have found. So again, keep in mind the cultural setting, and keep in mind that you're going to mostly see this in childhood, but it can be any age. This is also the category where we're going to see anorexia nervosa and bulimia nervosa. In anorexia, we're going to have 3 essential features. There's a persistent energy intake restriction, so avoiding eating, an intense fear of gaining weight or becoming fat, and or behavior that interferes with weight gain. And that this disturbance has, there's a disturbance in the self-perceived weight or shape. So there's often some level of body dysmorphia in folks that have a diagnosis of anorexia nervosa because they often will see themselves as overweight or having a lot of fat on their body, even if they tend to be underweight to the point of this being a health issue. There are subtypes of binge eating slash purging and restriction. You will often see with people who have a diagnosis of anorexia nervosa an obsessive compulsive behavior that's related to food. It could be thoughts of food, collecting recipes, hoarding food, or it could be some non-food related obsessive compulsive activities. And this kind of makes sense because what I see often is people who have this diagnosis often have some kind of stressful life event that has happened, and they're trying to regain some form of control over their life. This is an area where people might feel that they can control things, even if they can't control other things happening in their life. And often this happens during adolescent or young adulthood ages. So, an example of this might be something like if we have a young person, say of middle school, of high school age, whose family is going through some turmoil, maybe a divorce, a separation, something like that. They might feel out of control. So, to be able to have a little bit more control over things happening in their life, they might begin to restrict the amount of food that they're eating, or they might do something such as extreme exercising to try to avoid gaining weight. But there's going to be activities to try to regain some kind of control. Um, so that's something that's really useful to think of. I've had not clients, but a family friend that had a death in the family when she was a young person. And I think that that is actually what pushed her in the long run into becoming someone who has this diagnosis, because even though the rest of the family was very supportive, that was a situation that felt out of control, probably dangerous, probably scary as a young child. So that can become a way of trying to regain some control. It is important to note that this is kind of a long-term diagnosis, but it is something that can go into remission. So most people will experience remission within 5 years of the presentation. So 5 years is kind of a longer period of time. So it is something that can be a little bit more long-term, but definitely something that can go into remission, but also something that can be reoccurring. So if this is something that people have had in their earlier age, it could be something that becomes problematic again later on. Bulimia nervosa is often, it's not really compared to, it's also in the feeding and eating categories. So in this category, we're going to see a couple of different behaviors, but the three essential features for bulimia nervosa is the recurrent episodes of binge eating and feeling out of control while doing so. Some kind of recurrent inappropriate behaviors to try to prevent weight gain. So that could be um, extreme exercising, it could be purging or throwing up, and a self-evaluation that is unduly influenced by body shape and weight. Typically, what we're going to see is that people are trying to hide symptoms of this. And what they're hiding is often that vomiting. Vomiting is the most common purging behavior, but people might not want other people to know that that's what they're doing. So they might only do the binge eating and throwing up in the evening or when they're home alone. Or they might go to a bathroom on the farthest part of the house as soon as they finish eating so that they can throw up without people hearing. There's going to be something to try to hide those behaviors. It is also important to note that um, in folks who have a diagnosis of bulimia nervosa, we're usually going to see normal or slightly overweight folks. So in anorexia, people are typically underweight, and that is often a severe underweight to the point of it becoming a medical issue. In this category, we tend to see health issues in different areas. So we're going to see normal or overweight folks. And instead of having issues with not getting the nutrition or the calories needed, like in anorexia nervosa, we might have issues, especially with the vomiting. You can imagine if someone is bringing that acid up through their throat, their teeth, their gums, that's going to have some issues. So this might be folks who often have to go to the dentist because the acid from the vomit is eroding parts of their teeth. We're often going to see this in adolescence or young adulthood. Our category of elimination disorders is going to start on page 399, and these are going to involve the inappropriate elimination of urine or feces, usually in childhood or adolescence. They can be co-occurring or separate with both other disorders within this category as well as outside of this category. So there's really two that you're going to see. Enuresis is the voiding of urine into bed or clothing, whether involuntary or intentional. Usually it's involuntary. The main thing we're going to look at for this is that the child is at least 5 years old, because we want to know that there is the ability to have that control, or there was previously that ability to have control, and that there is now an issue in this area. So this could be involuntary because they've had maybe some kind of regression due to a trauma, or it could be intentional as some kind of attention-seeking behavior. And copresis is the repeated voiding of feces into inappropriate places, usually involuntary as well. The person is at least 4 years old, and often there's a lot of feelings of shame and people that are trying to avoid situations. So if the child is maybe a little older than 4, maybe they avoid going to sleepovers because they're afraid, or they don't want to go on sleepovers because they're afraid that they're going to poop their pants in the middle of the night. Typically, we'll see both of these happen mostly in younger folks again, and usually after some kind of traumatic or stressful event. So typically there's some reason why this has come back, and that's what you're going to work on in therapy, is the reason, not the actual bedwetting or whatever it is. That's going to be really hard to work on without going into some of the reasons why. We have our sleep-wake disorders. There are 10 different categories or disorders within this group. And you'll note that there's often those co-occurring diagnoses, specifically of depression, anxiety, and some cognitive changes. And that kind of makes sense when you think about it. If someone just cannot sleep, or maybe they're sleeping all the time, or whichever version it is, maybe there's some depression going along with not being able to fall asleep, and that they're always feeling exhausted and that they're never going to feel better. We do note that there's also an established risk factors of other mental illnesses, including substance use disorders. And the substance use disorders really makes a lot of sense, because you can imagine if someone is not able to sleep, they might over time turn to specific drugs to try to encourage that sleep to take place. So a couple specific things you might see in this category. This is definitely one where I think people start to self-diagnose once they start reading about it. So be careful about overdiagnosing yourself or people in your life. But insomnia disorder is a fairly common one. About a third of adults report some symptoms of this. 4 to 22% meet the criteria for the actual diagnosis. The essential feature for this is that dissatisfaction with the sleep quantity or quality, with complaints of difficulty initiating or maintaining sleep. And this can occur at different times in the sleep period. So some people have a really hard time falling asleep, but once they fall asleep, they're fine. Some people fall asleep fine, but they can't stay asleep. So they'll complain about waking up a lot during the night, or they wake up at a certain time and just cannot fall back asleep. Often these complaints are going to be accompanied by distress or impairment in social, occupational, or other areas of functioning, and also often associated with a physiological or cognitive arousal and conditioning factors that interfere with sleep. This can happen at any point in a person's life. Often the first episode will be in young adulthood, and this can happen for lots of different time periods or situations. It can be a situational insomnia, could be persistent, long-lasting, it could be recurrent. Sometimes there's also just episodes that happen when there's stressful events in life. I don't hear or see this one nearly as much, but you have heard of it, I'm sure. With narcolepsy, we're going to see recurrent periods of irrepressible need to sleep, lapsing into sleep or napping at least 3 times per week over 3 months. So we're really going to see that essential feature of recurring daytime naps or lapsing into sleep. And that's going to be when people are kind of just falling asleep randomly. So it's not that they are having insomnia issues, it's just that they can be going throughout their day and they'll maybe be in the middle of a meeting or even driving and just fall asleep. There is often some issues around cataplexy, which most commonly presents as brief episodes of sudden bilateral loss of muscle tone. And that's why you might see a head bobbing, a jaw dropping, something like that. You might see people not having any memory issues related to this. So some of those automatic behaviors could be that person's just kind of walking around, moving through the motions, but they aren't really conscious or aware of what they're doing and don't remember what they're doing. Another issue that you might hear about is nightmares or really vivid dreams. Some people experience sleep paralysis when they're falling asleep or waking up. And that is where people are conscious, but they can't move. So it's like they're frozen in their own bodies. And that can be quite distressing as well. That might actually be the part that they come to you to help try to resolve. So that is narcolepsy. You might see that on occasion. You might see that in addition to other co-occurring diagnoses. And our last category for today is the sexual dysfunctions. This is a group of disorders that are typically characterized by a clinically significant disturbance in a person's ability to respond sexually or to experience sexual pleasure. Someone can have multiple dysfunctions at the same time. We're again just going to go over a couple of them. But if you do see multiple kinds of dysfunction, make sure you diagnose all of them. The time of onset might have some indications as to what is happening and what kind of intervention you're going to take place of. Keep in mind if this is explained as part of another disorder, some examples might be depression, bipolar, anxiety, PTSD. Only the other mental disorder diagnosis is going to be made. So that's going to become a part of the symptoms of the other disorder. So when we are working with men, we might have some folks that are coming in for erectile disorder that is characterized by the repeated failure to obtain or maintain erection during partnered sexual activities. And in this case, you're going to want to take a really careful sexual history, determine if the problem has been around for a while. If it happens in most encounters, maybe it's only one situation. Maybe the person has been partnered for a long period of time and it only happened, this is only happening recently with that specific partner. Part of why you're taking this history is because the timeline is going to be really important. Typically, this is going to be something that is happening for some kind of emotional reason. So you're going to work on treating the mental health challenges so that those can be resolved and then their functioning in this area can be better. Often you're going to see a lot of low self-esteem, low self-confidence, and that decreased sense of masculinity. That's going to be part of the issues that we're working on. And we don't really know how often this takes place. As you can imagine, this is something that is not usually voluntarily shared, and a lot of people will not come into treatment for this. Similarly, with the female orgasmic disorder, this is characterized by difficulty experiencing orgasm and or marked reduced intensity of orgasmic sensations. For the women, we're going to look at if this is, again, experienced in all or most occasions of sexual activity, or maybe it's only happening with one specific partner. There's going to be some kind of clinically significant distress, as with many of our diagnoses. Often there's a lot of different causes going on at the same time. You might note that a lot of women will have difficulty communicating about their sexual issues. And again, because of that, we don't really know how often this occurs. So that 8% to 72%, that is a really wide range that basically tells me we don't know. So with both of those diagnoses, One of the things that you're going to note is that in a lot of settings, you're not gonna see these as a primary issue that people are coming in for treatment. Usually, you're only going to see that if the therapist is specializing in either working with couples or if they're specifically um, trained and working to resolve sexual dysfunctions in people. So, a lot of the times, these are things that only come up in specific segments of treatment and not something that's going to be widely seen in all settings. So, you may or may not actually work with folks very much in these areas unless that is something that you are specially trained in. So, that is the end of our discussion for this week. We will continue on next week with our next set. Thank you and have a great rest of your week.